So I'd like to proceed to the next speaker. Next speaker is Dr. Kim from Korea. He is online and is he connected?
Yes, I'm Jangyong Kim.
Okay. Okay. Please start your lecture, Dr. Kim.
Yes, I'm. Thank you for inviting me. This aortic master 2020. 84-year-old man presented and referred from my colleagues due to recent increased sex size, uh, 6 years after EVARs, and he underwent endurance stent placement 2016, and after 3 years after, he underwent lumbar artery embolizations due to type 2 endoleaks from other interventionists. And now he referred to me for the continuous sex size increase, even though it's not a big size increase. This is a video presentation. So this is a initial EVAR procedure, and the patient has a type 2 endoleak after that. So my colleagues did transarterial embolizations by lumbar arteries 3 years ago, but there was a still remnant type 2 endoleaks here, as you can see. So we can consider the trans lumbar approach or trans abdominal approach for this case. So my colleagues, aneurysm is quite big, and we can approach the type 2 endoleak from trans abdominals. So we decide to approach trans abdominal embolization. So he's my colleague, interventional radiologist. He looking for the patent type 2 endoleak from the ultrasound. So he tried to puncture the abdomen with 21 gauge Shiva needles. As you can see, we can see the type 2 endoleaks in the bottom of aneurysm stack. So he tried to looking for the patent type 2 endoleaks, but this lesion is the thrombosed lesion. So he's continue to do the angio to find the patent type 2 endoleaks. So this time we didn't find the patent type 2 endoleaks. It took 20 minutes to do the translumbar approach using the ultrasound. So CT scan, we think about the CT guide punctures for to find the lesion. So after that, we do the cone beam CT to localize the patent type 2 endoleak lesion. Sorry. Even though he do the multiple puncture to localize lesions, it was not easy for the ultrasound localization. So this time we do the cone beam CT. This is target. Sorry, we need to go back. we do the convexity and we localize the target lesion and we puncture. The localizations using the convexity like this, it was not difficult. We just follow the target line from the convexity scan. And then we switch the CT to localize the target lesions. And we found that there is a patent type 2 endolymph here. So in Korea, we have onyx liquid embolic agent. So we try to embolize these lesions using onyx. Onyx is easier to use than histoarterial embolic agent. We use 2 cc onyx for this time. Once it needs 3 minutes for infusion of 1 cc onyx for each session. Before the infusion of the onyx, we need to DMSO to flushing the blood, and then we use onyx for each for 3 minutes for 1 cc onyx infusions, because it can be washed out and to pass through the other arteries, and there is a risk of disembolization. So slow infusion is very important. So onyx was introduced and reimbursed from the health insurance nowadays. We use we have a 6 cc bottles onyx, and we can use around the 6 cc's from the 1 bottles. We infuse very slowly.
Results of this work, or it's just, I don't know, right? Yeah.
And we do the angiogram. Any full blockage of type 2 endolymph, and there was low flow from the angiograms. So we just infuse 2 cc onyx for this session. And then before the finish, we repeat the combine CT to localize locations of infused onyx. And we found that onyx was well infused within the aneurysm sac without any distal embolizations. So this is a case for the treatment of type 2 endolymph using onyx from the transabdominal approach. Yeah. Thank you for listening.
Thank you, Dr. Kim. Very nice, sophisticated techniques to puncture aneurysm under the CT guidance. My question is, are you doing this technique after sac enlargement was confirmed 2 years ago after or 3 years after the initial EVA procedure?
Usually, around the 10 years ago, type 2 endoleak, we observed the type 2 endoleaks, even though it was persistent. And these days, we have more cases, sex size increasement with the persistent type 2 endoleaks. And Japanese vascular surgeons, Dr. Morikage, he did the randomized control trial, whether he used embolized IMA or not during the initial EVAR, and he explained that treatment of type 2 endoleak prophylactically is very important for the long-term stent graft safety. So we think about do more treatment of the type 2 endoleak these days.
All right.
Professor Kim, Boon here. Thank you very much for your lecture.
Thank you for inviting me.
Thank you. No, thank you. I have two questions. Number one, what is your threshold to deal with the type 2 endoleak? When you're going to do the embolization, 5 millimeter enlargement, and you do it, or you wait until 1 centimeter or 2 centimeters? How soon you will attack it?
You know, usually the 5 millimeters sex size increment is definitely the failure of a stent graft, I think. So any increasement with a type 2 endoleak, I think, is indicated for the treatment of a type 2 endoleak.
I see. Okay. And what about the transarterial approach? Do you use it, or you recommend the direct puncture will be better?
If the IMA patent, these days I try to use SMA IMA approch. But
Okay.
if IMA is blocked, I try first to the transarterial approach from the internal iliac artery. But the transarterial from the internal iliac artery approach is a very low success rate. So in that case, I do the lumbar or transabdominals. I have one case with the transvena cava approach. We have around 40 cases treatment of type 2 endoleaks. Not quite big experience, but you know, so every method has a pro and cons.
Oh, thank you. Thank you.
Panelist, Dr. Coming, do you have...
Dr. Kim, thank you very much for your presentation. I'm coming from Thailand. I was wondering about the first line treatment. As you mentioned, for the IMA, you approach from the SMA. That is a very good option. However, for the lumbar artery in my hospital, my radiologist try to transarterial approach first. You mentioned that the translumbar approach in the prone position, you prefer this one. Can you compare the result of your treatment between the translumbar approach and transarterial approach for the lumbar artery? What is it a different outcome or the same outcome?
My data cannot reach any conclusions between two approaches. But we experienced that we need a multiple approach to control the type 2 endoleaks. One approach is not enough. So in the many literature review, they say that treatment of a type 2 endoleak need to multiple approach rather than simple approach is not enough. So you need to block all the vessels. But most frequently the IMA patent or not, if patent SMA IMA approach is very easy.
All right. Dr. Chom.
Dr. Kim, nice to see you online. Just wondering, for your approach, do you tend to identify large IMA preoperatively? Do you have a size criteria so you preoperatively embolize it? Certain operators recommend that. And then you also do that for the lumbar arteries. Thank you.
Still, I don't do prophylactic IMA embolization yet during my EVA procedures. But the Dr. Morikage from the Japan, he routinely do prophylactic IMA embolizations during the first EVAR. But I'm still observe at least 6 months to treat the type 2 embolics from the initial procedures.
All right. I would like to add something to Dr. Morikage's paper, and he is now trying to do prophylactic IMA and also lumbar artery embolization. And in my hospital also, we are now trying to do complete embolization of the branches of arising from the aneurysmal sac right now. It is a very difficult issue should be elucidated, as Dr. Boone presented long-term durability of the EVAR before your presentation. But we have to continue to discuss about this. Thank you very much, Dr. Kim from Korea.
Thank you. Thank you for inviting me here.